Welcome back to 12 Days in March. In this section, we will conclude our discussion of thyroid disorders with a focus on goiter, nodules, and tumors. So let's get started with a review of goiter. For purposes of this discussion, goiter simply refers to the diffuse enlargement of the thyroid gland. You'll shortly appreciate where nodules enter the discussion. So by definition, the patient is euthyroid. If they are hyper or hypothyroid, the glandular enlargement would be secondary to the underlying condition. For instance, if the patient was noted with a low T4 and a high TSH, your diagnosis would be primary hypothyroidism, with the two common causes being Hashimoto's or iodine deficiency accounting for glandular enlargement. If, on the other hand, the patient had glandular enlargement with a high T4 and low TSH, your diagnosis would be primary hyperthyroidism, and the common causes would be Graves' disease or thyroiditis, as reviewed in the previous section. Finally, if the T4 is elevated, but the TSH is also elevated, this describes secondary hyperthyroidism as seen in a TSH-secreting adenoma of the pituitary gland. In this scenario, the high TSH stimulates glandular growth and enlargement. So as is obvious following this brief discussion, the first step in sorting out the etiology of thyroid enlargement is to order a TSH and a free T4. The values inform us about the functional status of the gland. In all these instances presented so far, the enlarged thyroid would be described secondary to the underlying disorder. The patient who is euthyroid, as defined by a normal free T4, and does not have a palpable nodule, would be described as having a diffuse or simple non-toxic goiter. So the next question to answer is why the gland is so darn big. Part 1 of the goiter story involves TSH. It is still a trophic hormone, and it is still stimulating cellular growth. So what is going on in simple, diffuse, non-toxic goiter? I like to refer to this situation as hormone dysynthesis, my own descriptive term. You can call it a biosynthetic defect. On a global scale, relative iodine deficiency is most common. That is, a lowish iodide prompts TSH to stimulate glandular growth. The gland is able to keep up with adequate T4, but at the expense of growth. In the U.S., where iodine is plentiful, defective production of hormone prompts TSH stimulation. That is, there are relative defects or deficiencies in biosynthesis. These defects all prompt persistent stimulation by TSH. Again, the gland is able to keep up with adequate T4, but at the expense of growth. Let me be clear. Although there is an impairment in thyroid hormone synthesis and there is a rise in TSH, the compensatory increase in functional mass generates a euthyroid state. In these instances, the free T4 is normal, but the TSH may be slightly elevated. So pathologically, what is going on? The gland demonstrates one of two growth patterns. These are hyperplastic and colloidal. I will cover these, but I have to be honest. This is not a prime focus of NBME, so the coverage is a bit cursory. I think it is hard for them to design tricky questions on goiter, and there are so many other thyroid disorders, this topic isn't really on the radar screen. Okay, so we have these two growth patterns. They give rise to glandular enlargement under the trophic influence of TSH. The key point, growth is not uniform. Different cells or follicles develop different growth characteristics, and you'll see why this matters in a second. Under the influence of TSH and defective biosynthesis, the follicles undergo cycles of hyperplasia, and then they undergo cycles of involution. Different follicles are in different states of hyperplasia and involution at different times. This is not intuitive, it is a little sick, and it's not that important, except this process takes us from goiter to multinodular goiter, as you will see in a moment. So the key point here is goitrous glands undergo this perpetual cycle of hyperplasia and involution. This cycle is part of a continuum that leads right into our discussion of multinodular goiter. So let's walk through this. These ridiculous illustrations pretty much tell us everything we need to know about goiter, multinodular goiter, and toxic multinodular goiter. So we start with the normal-sized thyroid. In the setting of relative iodide deficiency or biosynthetic abnormalities, the gland enlarges under the influence of TSH. In time, and resulting from the cycle of hyperplasia involution, and differing sensitivities of follicles to the effect of TSH, nodules develop. They have no capsule. In time, like over months and years, these nodules experience a variety of outcomes. A patient can hemorrhage into a nodule characterized by sudden growth or appearance of a large nodule. They can involute. A nodule can scar and or stand out as a solitary or dominant nodule in the gland. A nodule can develop autonomous function-secreting hormone without regulation. The multinodular gland is a work in progress evolving over a lifetime. So let's tie up some loose ends. Simple goiters can be described as endemic, related to iodine deficiency, or it can be described as sporadic, as in defective biosynthesis, including that seen by ingesting goitrogens such as cauliflower. The patient with goiter, of all types, can also present with compressive symptoms, including hoarseness, shortness of breath, or dysphagia. As for multinodular goiter, be aware of the following. The pathology can include descriptions of fibrosis, calcification, or hemorrhage. The patient may have compressive symptoms, just as reviewed. They can hemorrhage into a pre-existing nodule. These patients present with sudden onset of a large new nodule. The patient may have a cold or hypofunctioning nodule, as we'll discuss shortly. The main goal in these patients is to rule out malignancy. Finally, the patient may have a toxic or autonomous nodule. We know these are benign, so we would focus on treatment. I-131 or antithyroid meds would be the mainstay of management. Surgery is not indicated, as a functioning nodule is not cancerous. In all the discussions so far, the free T4 would be normal. The TSH may be normal or slightly elevated, with the exception of a hyperfunctioning nodule. The material just covered describes more than you need to know for the boards regarding goiter and multinodular goiter. Very few questions on this topic. I tried to keep the presentation to a reasonable minimum. But let's move ahead. There is one nodule that warrants further discussion. The follicular adenoma is separate and distinct from the nodules just reviewed. They're easiest to review and understand by highlighting those differences. So how does the adenoma compare with multinodular goiter? The follicular adenoma is solitary. Secondly, they are encapsulated. Remember this important fact. Third, they can develop autonomous function. A hyperfunctioning or autonomous nodule would be referred to as a toxic adenoma. They are distinguished from toxic multinodular goiter in being solitary and encapsulated. Finally, if cold on radioactive iodide uptake or hypofunctioning by serologic studies, one would need to rule out malignancy, just as in a solitary or dominant nodule associated with multinodular goiter. This overview covers the majority of what we need to know about follicular adenomas. Let's review pathology, presentation, and treatment, and we'll be done with goiter and nodules. In terms of background, as stated, these are solitary nodules that may or may not be functional. Mechanistically, they are associated with a gain-of-function mutation that may or may not be associated with autonomous function. The pathology reveals well-differentiated follicular epithelium with normal-appearing follicles. As mentioned, they are encapsulated. The reason the capsule is such a big deal is because the intactness of the capsule distinguishes a follicular adenoma from carcinoma. We'll revisit this when discussing carcinoma. And for completeness, Hurdle cells may be present. Recall, we mentioned Hurdle cells in our discussion of Hashimoto's. Clinically, a solitary nodule is present. I've mentioned this 20 times. They may be functioning or not based on the free T4 level. And that brings us to diagnostics. Obviously, a T4 is obtained. If elevated, a radioactive iodide uptake is obtained. If a hyperfunctioning nodule is seen, the patient has a toxic adenoma, which we will know to be benign. A hyperfunctioning nodule will be treated with radioactive I-131. So if the nodule is cold by serology, an FNA will be performed. Only problem, FNA cannot distinguish adenoma from carcinoma, as they are distinguished only by capsular invasion. An FNA cannot define capsular invasion. As such, a cold nodule will either be closely followed by ultrasound or be surgically excised. Just a note of clarification, the FNA is done because we have a cold nodule. It may be papillary or anaplastic, so FNA isn't done to define follicular adenoma versus carcinoma. The FNA is simply trying to define the pathology. So I will stop this recording here and in the next session we'll resume our discussion of thyroid cancer.